Thanks, Professor GB. And I would be debating for the topic use of immuno-oncology molecules in the first-line management of PD-L1 negative advanced non-small cell lung cancer. So why are we still debating this? The answer is a vehement yes. I am going to use IO molecules. I have been using this for the last couple of years, and I am going to use this today. And as Dr. Bharat said, on Monday morning in my clinic as well. A short disclaimer before we go forward. This is an academic debate. I know my learned colleague also works with one of the biggest hospitals in Kanpur, and I'm sure logistics and affordability won't be such a big issue for his patients. So I'm not certain we should be debating logistics or affordability. So I would like to stick to the science behind my current claim. So what are the two molecules that we use in first line management of advanced non-small cell lung cancer? First is atezolizumab, which is a PD-L1 antagonist, and then we have pembrolizumab, which is a PD-1 blocker. What was the rationale for combining atezolizumab with chemotherapy? So ATI has the ability to restore anti-cancer immunity by preventing D-cell deactivation, and chemo-induced immunogenic cell death will lead to release of tumor antigens. So the goal of a chemo-immuno combination is to create a more favorable environment to maximize the potential of the immune system to eliminate cancer. So the first trial that I would discuss here is the IMpower 130. The thing which I want to bring out here is that IMpower 130 included all comers. It did not select out the PD-L1 positive patients. So the intention to treat analysis included all comers over here. This was a straightforward differentiation between ATI plus chemo. The chemo backbone here was carbonapacli, and the arm B, which was standard of care, was the carbonapacli arm. Maintenance was allowed with pemetrexed in the chemo arm and with ATI in the experimental arm over here. The trial was designed in such a manner that the co-primary endpoint was investigator-assessed PFS and overall survival. So another thing that my own teachers have been telling me from the time of training is that in a metastatic setting, any trial which chooses overall survival as an endpoint, the investigators have to be very, very confident that this would do well. Without that level of confidence in the drug, overall survival usually is never picked as a primary endpoint also. And they were quite right in having such a big confidence. The investigator assessed PFS was significantly improved with the addition of ATI to the carbonapacli combination. At 12 months, 30% of the patients who were on the chemo-immuno combination continued to be progression-free, whereas that was only 15%. So at the landmark 12-month PFS was doubled with the addition of atezolizumab to carboplatin and nab-paclitaxel. As we can see from the KM curves over here, the hazard ratio was 0.64, and this was statistically significant. Overall survival was also significantly improved in the ATI chemo arm versus the chemo only arm, despite 59% of the patients in the control arm receiving subsequent chemoimmunotherapy, and this included 40% crossover to ATI. So in spite of a crossover, there was still a statistically significant overall survival benefit. 40% of advanced non-small cell lung cancer patients who were all comers were alive at the 2-year mark. So IMpower 130 concluded that this was a positive phase 3 study, providing an alternative chemo-immuno combination for patients with chemo-naive non-small cell lung cancers. This trial demonstrated a statistically significant and a clinically relevant overall survival benefit when ATI was added to carbonapacli. And OS and PFS benefit was observed across key clinical subgroups. And I'm not going to be talking about our patients who are target therapy naive and who have driver mutations. Another area which my colleague would definitely want to debate about is the safety profile. ATI plus chemo had a safety profile which was consistent with adverse events associated with the single agent therapy, and there were no new safety signals identified over here. The other landmark trial with atezolizumab was the IMpower 150 trial. This went one step further. It added an anti-VEGF in combination with immunotherapy and the chemotherapy. So this again was a 3-arm trial. Arm A was ATI with carbopacli, arm B was ATI carbopacli bev, and arm C was carbopacli bev. And here the primary endpoint was again investigator assessed PFS and overall survival in the intention to treat population. Maintenance was allowed depending upon what arm the trial patient was on. There was a significant overall survival benefit with the addition of atezolizumab to the carbopacli bev versus just the carboplatin arm. So if we want to debate and say that the benefit in non-small cell lung cancer has come because of the anti-VEGF and not because of the IO molecule, we can clearly see when we try and compare the arm B and arm C, in spite of adding IO to the anti-VEGF and the chemo arm, there was a statistically significant overall survival benefit. At 24 months, 43% of the patients were alive in the arm B, which was a experimental arm, as compared to arm C. The hazard was 0.8 and it was statistically significant. So the improvement in median survival was 4.5 months. And considering that we are dealing with, stage 4 non-small cell lung cancer, this is definitely clinically meaningful for all of our patients. Another point which my learned colleague would want to debate about is that these trials could have been skewed by including all comers, and they did not separate out the PD-L1 positive and the PD-L1 negative patients. So this slide shows that even in the set of patients who were PD-L1 negative, which means that their TC score was 0 and their IC score was 0, the overall response rates for a patient who went on the chemo plus anti-VEGF plus IO arm was 51%, as compared to only 36% for patients who received just the carboplatin arm. The median duration of response was 8.2 months when the patient received ati-bev carboplatin, as compared to 5.5 months when patient just received the carboplatin. So the overall survival in this trial was observed across all PD-L1 subgroups, including the PD-L1 negative subgroup. And here the overall survival benefit was another added 3 months. So the OS in the PD-L1 negative subgroup was 3 extra months at about 17.1 months. So this trial summarized that, this trial met both its co-primary endpoints, and it was the first and only chemo plus anti-VEGF plus IO trial which demonstrated a statistically significant and a clinically meaningful improvement in PFS and OS in all comers first-line non-squamous metastatic non-small cell lung cancer. Again, there would be questions about how a 4-drug regimen would be tolerated by many of our patients. So this trial also concluded that atezolizumab in combination with chemo, with or without bev, appeared to be well tolerated, and its safety profile is consistent with known risk factors. If our weapon of choice is going to be pembrolizumab, and this was the earliest IO with a wealth of data, here is the exact question that we were debating, and this was presented at the World Lung Cancer Congress in Spain 2019. This was a pooled analysis of the Keynote 21, Keynote 189, and Keynote 407 trials, and this looked at pembro plus chemo for advanced non-small cell lung cancer patients without PD-L1 expression. So Keynote 021 was a phase 2 trial, Keynote 189 and Keynote 407 were phase 3 trials, and both of these had pembro at a dose of 200 milligrams plus pemcarbo or pem-cis versus placebo plus pem-platinum as the comparator arm. In the Keynote 407, the chemo backbone was changed from PEM to a paclitaxel or a nab-paclitaxel along with carboplatin as the other chemo molecule. So if we look at the pooled analysis of the patient population, nearly 500 patients, so it's not a small number, it's not a 2-digit number, nearly 428 patients were included in this who had a PD-L1 TPS score of less than 1%. This is exactly the question that we are debating. Of this, about 243 went on the pembro chemo side, and about 185 went on the chemo alone side. The important thing that we need to see is that the patient withdrawals in the arm, and if we think that adding IO to chemo in a PD-L1 negative setting does influence the adverse event profile and the patient tolerability, the patient withdrawal was sort of similar. There wasn't too much of a difference with the chemo arm versus the pembro chemo arm. When we look at the baseline characteristics, we know that of the pooled analysis, about 40% of the patients had a squamous histology also. So it does not mean that you can just specifically say that yes, IO chemo works only for the adeno and it does not work for squamous. So if patients had a squamous histology, then definitely they also could potentially go on the IO chemo combination. Liver mets was again something which was very interesting. We always want to try and get a quicker response for patients who have liver metastasis, and we were trying to see if IO makes a difference when we add it to chemo in this particular setting. So I think this overall survival, this slide should have been the theme for all of my other slides. We can see that the Kaplan-Meier curves separate quite early, and they separated for a fairly long time. The median overall survival in patients who had a TPS score of less than 1% was 19 months in the pembrolizumab with chemotherapy arm, as compared to chemotherapy alone arm, which had a overall survival of only 11 months. So 11 months versus a year and a half, less than a year versus a year and a half. What would you want to counsel your patient when we go back to the clinic on Monday morning? So across various subgroups, the pembro chemo arm did better than the chemo alone arm in patients who didn't have a PD-L1 positive expression. When we look at the progression-free survival, again, there was a statistically significant improvement in the median PFS when patients went on the pembro chemo arm versus the chemotherapy alone arm. Here again, the hazards were a very significant 0.67. When we look at the overall the objective response rates, and more importantly the median time to response, not too much of difference between the pembro chemo versus the chemo alone arm. The median duration of response was better as expected in the pembro chemo arm. Very significantly, if we look at the Kaplan-Meier estimate of response duration of more than 12 months, 42% had a response duration of more than 12 months in the pembro chemo arm, as compared to only about 35% in the chemo alone arm. Again, the estimated difference here was about 18%, which is very significant. So this pooled analysis concluded that in patients with a previously untreated advanced non-small cell lung cancer without PD-L1 expression, pembrolizumab plus chemotherapy provided clinically meaningful improvement in overall survival. Hazards of 0.56 and 0.67 cannot just be dismissed by saying not a good biomarker over here. OS benefit was observed in all patient subgroups. Pembrolizumab plus chemotherapy had a manageable safety profile, albeit with increased immune-mediated toxicity. Pembro plus chemo is the standard of care first-line therapy for patients with advanced squamous or non-squamous non-small cell lung cancers in patients without a PD-L1 expression. This is a category 1 recommendation from NCCN 2022. In patients who do not have a PD-L1 expression with advanced NSCLC, the preferred would be pembro carbo pem as a category 1 recommendation. Pembro cis pem is also category 1. If we like to use ATI, then ATI carbo paclitaxel is a category 1 recommendation over here as well. So to conclude everything, there is phase 3 data with the overall survival benefit. There is NCCN recommendation, there is USFDA recommendation, and although we like to, as clinicians, we like to make our own, come to our own conclusions, there is an overwhelming body of fairly experienced clinicians who have recommended in the PD-L1 negative non-small cell lung cancer without a driver mutation, immunotherapy with chemotherapy as a standard of care, and in Perry Mason's absolutely immortal verse, therefore your honor, Dr. GB sir, I rest my case.